Hi YouTube, this is Dr. Margolin. We are part of the Comprehensive Pain Management Institute, which is a comprehensive multidisciplinary program here in central in northern Ohio, in Columbus and Cleveland, Ohio, which is the epicenter of opioid epidemic. Since 1999 till 2017, at least 700,000 people died in the United States from opioid epidemic, and since then, unfortunately, the number of overdoses did not go down despite some efforts to control it. Ohio is one of the highest states in terms of deaths per thousand people. We have a lot of experience in treating both chronic pain patients as well as screening high-risk patients. About 30% of our patients are African American patients, Latino patients, Asian patients, immigrant population. We're very culturally diverse. Our staff speaks many languages, including obviously English, Spanish, Russian, Mandarin, Chinese, Korean, Hindi, and other languages. We recently made a presentation at Case Western Reserve University Lifelong Learning Program at the meeting called the Opioid Epidemic, Where Are We Now?, which addresses the efforts to combat the epidemic and suggestions on what else can be done. We received several requests from referring providers, from patients, and even other participants of the meeting who did not participate in our presentation to share the presentation with them, which I'll gladly do. I will let our patients to say a few words, and then without further ado, we will share the presentation. Thank you again for everybody who supports this YouTube channel, who supports and participates in our program. It means a lot to us. Thank you.
My name is Edward. I've been a patient of Dr. Margolin's for quite a while, and through his help, I was able to become gainfully employed again. Without him, I would still be in severe pain and not have a job.
Okay, my name is Daniel, and I would just like to tell all the new patients that Dr. Leon Margolin, he's very genuine. You can eye talk someone and see when are they truthful or are they lying. He loves his patients, and he have helped me out so much. So you must give him a chance, because he's going to give you a chance. And I'll let you know, I'm 50 years old, and he's a good doctor.
Hi, my name is Sally Plummer. I've been coming to Dr. Margolin for 2.5 years, and it's been a wonderful experience. I've been searching for a doctor for a long time, and we don't know what we'd do without him.
Hi, my name is Louis Lamar, and I've been coming to see Dr. Golden for about 5 years. He has always helped me with my pain because I have back pain, hip pain, and he has always been there for me. And I recommend anybody that need help, come to Dr. Margolin. He's a true doctor, and he's a true friend. Thank you.
I'm someone who has been in severe pain now for, let's see, 8 years. And during those 8 years, I've got some pain relief, but never a lot of pain relief. And I was starting to get pretty hopeless. When you're in great pain for a long time, you really wonder how much you want to go on. And when you get someone who respects you, who listens to you, and who tries things that nobody else bothered to try, things start looking up, and all of life starts feeling better. And one of my great joys in life was helping other people, and I've been in too much pain to be a helper to other people. And now I look forward to getting back to life. So I really appreciate Dr. Margolin, and I think you will too.
Hi, my name is Tammy Franklin. I am a patient with Dr. Margolin, He gave me my injections for my knees, and since then, I was able to do more on my exercise and rehabilitation. I'm actually now on the treadmill for 20 minutes, the bike for 20 minutes. I'm doing 10 sets of squats. It works excellent.
Hi, my name is Linda Adams, and I am currently a patient of Dr. Margolin. He has been a great person and supporter of the problems that I have had. He is very delicate, very explanatory, and very kind. He makes having a situation like this easier to deal with.
Hi, my name is Angie, and I've been coming here since 2011, and I've had a lot of back pain, but since I've been coming here, it's been controlled, and I'm very happy and pleased with coming to this doctor.
Hello, good afternoon. My name is Dr. Margolin. I understand I'm the last speaker, and I'll try to keep everybody awake, and I'll try to communicate my points clearly. And let me explain to you what is the purpose of this talk and why it might be important. I was trained in pain medicine, in interventional pain medicine. We came to Ohio about 10 years ago, and we ended up in the epicenter of the epidemic. And why screening and brief intervention with extensive routes are important? Because most people, at least at the early stages of addiction, do not come to their primary doctors and say, hey, I'm a cocaine addict, could you find me a program? They say, well, I've that thing, maybe, I moved something heavy, it hurts, well, that shoots down the leg, they go online. And they're sent to pain management. And here we are, I'm pain management, and I would say 80% of my consults have a question. Is this person a good candidate for pain medication? So here we go. So here is the perspective that we have and the challenges and how we deal with it. So I just show you this pain medicine use edition that says opiate overdose now leads to more death than motor vehicle accidents. A lot been said. I'm not going to repeat it. It's pretty obvious, especially in Ohio. Why people die? It was also mentioned. This is research from National Institute of Drug and Addiction that shows that heroin and fentanyl are the leading causes of death. Now, what happened? Around 2011, around 2015, in Ohio, for example, there was a very reasonable attempt to regulate opioid prescription. But unfortunately, regulations don't change people. Regulations don't change people, as reasonable as they are. So without appropriate treatment system, these people go to the street. They get heroin, they get fentanyl. Fentanyl is on the rise. It's being shipped from overseas. I don't think it gets enough media coverage. I have a patient whose son went to college, and I'm going to end with the culture of college parties. He went to college, very good kid, but she says the first joint in his life and dropped dead because fentanyl was mixed. So we need to develop a system. How we screen these people? How we no, I can't read people's mind. I did go for a fellowship. I tried to go for a lot of CME. How we screen people? Who makes this decision? Now, the stakes are very high because if you give opioids to somebody who is untreated addict, it will cause overdose. If you push a legitimate patient with chronic pain in Ohio, there is a good chance he'll go on the street and self-medicate him or herself. So how we deal with that? One of the problems is that we deal with self-reported complaints, right? There is strong fear of social consequences. A lot of patients did not tell me the truth because they believe that I'm going to report to Social Security, to their job, I will go to talk to their family, and it's not what we do. But that's the fear that prevented them from telling the truth. And some of them have psychological comorbidities. They have anxiety disorder, they can have PTSD, they have major depression. and other disorders, and that makes communication even more challenging. So first, and these patients had nothing to do with addiction. They allowed me to use their pictures, but it shows that the first rule that I will tell you: build a rapport, build a good relationship. And sometimes this patient, I'm not going to tell his medical history, but he went through major hospital, and the problem is nobody talked to him. I think they took the distant care to him. Nobody took time. I don't blame him. I worked for hospital for 4 years, and the lady on the right, it was very difficult to establish this relationship. She's an amazing lady with a lot of medical problems until I noticed this doll and asked her, hey, what is she? She's legally blind. I asked her, what is this doll? And she said, it's Star Trek. So we talked about Star Trek for 15 minutes, and then she opened up and she said, you know, I've been knowing from this pain for 20 years, and I can see, but I believe there is this force outside me that keeps me going. And that we started talking, and I think it was a clinical success. Another thing, if a person has a service dog, you got to report with a service dog, you got to report with the dog. It really works. Now, I'm not going to repeat it, but these are the criteria of addiction from UCLA. And when I started, it seems like not rocket science to me. It's pretty straightforward. But the problem is how you obtain this information in a credible way from a patient. What can you do? One of the things we do is questionnaires. They're validated by studies, they're recommended by the medical board, there is risk certification. But here's the problem, it's something called SOAPAR, screening for patient and pain. What does this mean? Everything is zero. Person never had mood swings, never got angry, never got bored in his life. It means he Googled it. He Googled it, and it's not, there's a PDF file, and he read it. So that makes it much more difficult. Well, you can tell me, well, let's go to the urine screen. It's objective data. You can do point of care or you can do confirmation urine screen. But here's the problem with urine screen. You need to read and interpret them. And sometimes it can be challenging. And this is a classic triad we see in Ohio. Unprescribed fentanyl, unprescribed oxycodone, and ATOH. This person is a high-risk patient that needs immediate attention. Obviously, this is alcohol use, right? It's a very high alcohol level. And this is all pretty straightforward. Many times we get this. What is this low ethyl sulfate level? We have a pharmacology doctor with this. But it's a question, is it non-alcoholic drink? Is it remote drinking? There is no one way to read this urine screen. You need to match it to clinical history, and that takes a lot of time, which, as Tad mentioned, also have this problem. Many times, this is not reimbursed by insurance. They don't believe you need it. You don't need to take time to screen patients for drug alcohol. It's denied. Tester denies. Urine screens are limited in number you can do, and so on. This is another thing. It's a high level of oxycodone without metabolites. So it's most probably the person was adding oxycodone in the urine, just going to the restroom and dropping oxycodone in the urine. This one looks clean, except you see in the bottom it says common dilute. You know, just added water to the urine screen, and so on. We see that a lot, and that's the saliva testing from the same patient, which shows several substances. Again, opioid, hydrocodone, benzo, lorazepam, and marijuana. And it's pretty common, unfortunately, in this area. The point that I'm trying to make, it takes a lot to do and to interpret urine screen correctly, and one urine screen, primarily in primary care office, does not necessarily solve the problem. Now, we also deal with difficult patients. People are not happy when you show them urine screens that I showed to you, and some of them, see this cocaine or marijuana or whatever they see. It's hard to argue with them, and some of them act out. Even sending me these messages and calling me many times. It's not every other patient, but it does happen. And sorry for, that's the same person. And we have a hard time dealing with that. And we even feel that, as you heard my comments, that, legal system is not out so much to help us out. I mean, they follow the protocol, police shows up and says, we're so sorry, if the patient is here, we definitely would trespass them. But that's the most they do. So we decided to create some kind of screening system. That's the improvement we had over the last 5 years, that could reliably help us to do that. That's the point that I'm trying to communicate, and that's our experience. So we use several assessments at the same time. We use very thorough history and physical, and I liked my internship in internal medicine. It really helped me with a good basis of doing history and physical at a good level. Understanding medical condition, using several assessments, using functional assessment, using setting goals. That's this flowchart rule for 731 and Ohio. You need to set goals and follow up. And then confirming that with point of care and confirmation urine drug screen and ORSA report, right? Where you can, I have my 2 nurse practitioners here so they can confirm we are crazy on ORS. You can't go wrong with obtaining extra ORS. It only can help. We still run, as I mentioned, a third-party peers. They don't believe people should be screened or screened this often, even the high-risk patients that confirmed by NARCSCORE. Imaging, not approved, even though it's required by regulatory agencies. They don't care, they don't want to pay for MRI. Even for X-rays, we sometimes have problems. It's a good idea. It's sometimes challenging to put it together. We created videos. Now, reading levels differ in different areas we discovered, so as much as we try to write a good agreement or a good educational sheet to the given to the patient, they like to listen and watch. So we have a video, about 30-minute video about risks and benefits and the agreement, and then they're allowed to ask questions. We started a YouTube channel. Yeah, you can check us on YouTube. And I try to do it short and funny as much as I can. And we started for our patients, because everybody has cell phone, and some of them watching in the waiting area. No commercials on that, I can promise. So it's only done for patients. And actually now we see that most people who watch it are not our patients. And we do it for free. We're glad to contribute to the community this way. We also ran a small study on correlation between NARCSCORE and food addiction. And we found a correlation. We presented it at Family Medicine at some point, and it's a very short time, but we actually got an experience with lifestyle modifications, with exercise, diet changes, mindfulness. It does work. It does not cure addiction in my experience, and we have a small Suboxone program. It does improve the recovery rate. It does make it much easier to communicate with the patient. It does work. It's challenging to do it in a small private practice, but we definitely try. Now, this is a catch-22. We discussed about compliance and insurance. Even though the official guidelines for all insurances say that non-physicians should not tell physicians how to practice medicine, but if HMO tells you you're allowed 4 urine screens a year, or this is denied, or this would be seen as overpayment, we don't think it's medically necessary, and you deal with population that does not have means and it's not able to charge them, obviously they do tell you how to practice medicine, and let's be honest about it. We also did a study on the use of electrodiagnostic studies. Dr. Kimura, if you're familiar, is the author of the textbook. He agreed to guide us, and we found a good impact. Additional testing and additional specialists involved generally do improve outcomes. I mentioned the strategy to combat opioid use, abuse, misuse, and overdose. We were very happy. U.S. Department of Health and Human Services in 2017 had a larger scale meeting, I guess, similar to that, and they came up with those 5 points. And one of them, advanced the practice of pain management to enable access to high-quality, evidence-based pain care that reduces the burden for painful individuals. It sounds great. Since then, I'm not aware of any change, at least in our level. If you do, please let me know. I don't, but it's a great idea, and I hope it will be implemented. And again, from our point, we practice in an over-regulated environment. Ohio is seen by pain management as one of the 3 most difficult, challenging states to practice pain medicine. And I think switching from fear to cooperation and this wisdom of those who say I can and those who say I cannot do are both right, and that's true. I think we can change it. I think we can if we stick together and make an effort. And there was a comment, excellent comment about that you made about our society. I see the teens with, obviously, the picture about is Marilyn Monroe, right? I see those pictures on T-shirts, and she died from overdose at the age of 36. And it's like she's an icon, and some of them tell me, look, that's what stars do. That's in culture. That's what stars do. Do you know, guys, who is in the bottom? Anybody? No? I like this person. His name is Normal Bolov. Check. He was a humble scientist. He invented different strains of wheat that saved close to 1 billion people from starvation. I would say they estimate close to 100 million people in India were saved from starvation. Otherwise, he was a very boring person. He was not involved in any scandals, was married to the same woman for 50 years, and I don't see him on T-shirts. When we start seeing him on T-shirts, we know that the culture is changing. Thank you so much for your attention.